Ladies and gentlemen, please take your seats. Our program will begin in 5 minutes. Ladies and gentlemen, please take your seats. Our program is about to begin. Ladies and gentlemen, our program will now begin. At this time, please silence all cell phones and mobile devices. Thank you.
I've never been more confident, more excited, just more assured that we will see the change that we are seeking in ensuring that patients, families, caregivers' voices are heard, are respected, are incorporated into developing policy, into crafting measures, making decisions about their health care based on information and engagement.
We don't know what we don't know. So unless we have patients and the families and caregivers and all stakeholders together coming up with the solutions, we're not going to get to where we need to go quickly and efficiently.
We need a healthcare and social services infrastructure that is easy to navigate, that is flexible, that is affordable, and relentless in its person-centeredness.
So when we think about better, smarter, healthier, and the quality of care that we deliver, we take it incredibly personally in Medicaid and CHIP because we know the responsibility that we have on our shoulders to do right by the beneficiaries that we serve.
So we currently have efforts underway in 4 critical gap areas: reducing substance use disorder, supporting physical and mental health integration, improving care for Medicaid beneficiaries with complex care needs and high costs, and promoting community integration for individuals who are receiving home and community-based services in the long-term care area.
The Federal Office of Rural Health Policy has an existing quality improvement program, and we have 93% of our critical access hospitals reporting these measures. So I think that really demonstrates that hospitals are ready to report, they're ready to improve, and they're just waiting to be able to participate in quality improvement programs.
Such an important reminder when we hear from whether it's the adult daughter taking care of an aging mother, or the cancer survivor who's on a great long-term path, or the clinician who's engaged his patients differently. It's such a good reminder of why we do what we do in the quality improvement world.
Ladies and gentlemen, please welcome David R. Wright, Director of Survey and Certification Group within the Center for Clinical Standards and Quality at CMS.
Thank you. Good morning. What a nice introduction. With an introduction like that, with a voice like that, whatever I say is going to sound much more impressive. So I would love to have that guy do my outgoing voicemail box. That would be awesome. So I'm the director of our formerly Survey and Certification Group. We're now the Quality, Safety, and Oversight Group, and we changed our name because you can't be within the Centers for Clinical Standards and Quality and not have a Q in your acronym. So I'm glad to be here, and I'm glad to represent the quality assurance side of the quality improvement and quality of care continuum. And it's something that we take very seriously in our mission to safeguard the health and safety of every single person who accesses care in a Medicare certified facility. So it's a great conference. It's great to be here. It's great to share the energy that you all have. And I'm really honored to be here to welcome you on the last day and go over some of the things that we've covered to date. So first we have kind of the word cloud of the social media chatter. And I would point out a couple of things here. One is that you can see the Gene Moody Williams fan club is up and running in the upper right corner there. I won't say how many of those hashtags came from Jean's phone, but she certainly made an impact. And also, if you'll see down there, the cowbell made a run as well. So I think people are getting the message. People are getting the message that they need from this conference. And I will tell you that I was a little disappointed yesterday to hear that this was the 6th top trending healthcare conference in the country. That's no good. Frankly, I'm pretty disappointed. And so we're about improvement. And I know that this conference has been full of charges and goals and offers and things like that. So I have a charge for you. Next year, if 50% of you, just half, will bring a kitten to the conference. Take a picture with the kitten, hashtag quality conference, hashtag now with more kittens. I think we'll be at least fourth, and we'll continue to grow. Now, if you have a kitten that plays piano or has a grumpy face, that counts for 3 kittens. So if 1/3 of you bring a kitten with a grumpy face or plays the piano, I will probably be third. All right, so hashtag now with more kittens. I look forward to that trending next year. The other thing that I think we can do a hashtag of is hashtag I care because I'm here on Valentine's Day. Right? Thank you very much. So happy Valentine's Day, and you do care because you are here on Valentine's Day. Now, there's 3 reactions out in the audience when I just said it was Valentine's Day. One is a positive reflection of I'm wearing red, I've prepared, I have my gifts, I'm looking forward to a nice dinner or an event tonight. The other reaction is bitterness that I raised it. You don't want to think about it. You consider it as my dad did for 50 unsuccessful years of his marriage, that it's a Hallmark holiday and you shouldn't have to really do anything for it. And then the last group is in sheer terror at the realization that it's Valentine's Day and you haven't done anything at all for it. Now, for that group, there is a solution, and that is the airport has a pretty good gift shop. Guys, I'm going to give you some advice. I know you're desperate. I know you think it's going to be cute. I know you think it's going to be well received. Do not get the I'm a little crabby in Baltimore apron. That won't fly. Now, ladies, you have it easier. You can get the I'm a little crabby in Baltimore crab hat, and it'll be extremely well received. So good luck to y'all with regard to dealing with Valentine's Day today. And again, thank you for being here for that. We heard yesterday as well from my boss, Dr. Kate Goodrich, and she talked about reducing burden and in service of better outcomes. And the thing that we frame when we talk about this is we're really looking at effectiveness. And the focus in our group, and I think a way to look at reducing burden as well, is why are we doing something if it doesn't move the needle on quality? And that's what I think we need to focus on, is our activities, is the work that we're doing actually having a positive impact on quality? Is it helping to drive where we all want to end up? And within the Quality, Safety, and Oversight group, we're looking at things like our state performance oversight. So we work with state survey agencies that actually do the on-site inspections of facilities for us. We have a performance oversight process that really doesn't measure performance. In fact, it doesn't tie into quality indicators in facilities within those states. So we're looking to revise that and transform that process. We have a federal oversight process that's mandated by statute, where we send federal surveyors out to 5% of nursing homes across the country, but it's not tied into the quality of care in nursing homes. It's a performance oversight of the state. So we're changing that process to incorporate quality measures for individual nursing homes as well as for those within the state, and use that process to try to drive, again, those quality metrics. And so we need to take a look at, not only are we doing things that don't move the needle, but are we doing things that are already in place that we can transform and better utilize those resources and be more effective in the goals that we're trying to meet. One thing that we've done in Survey and Certification in the Quality, Safety, and Oversight group is we've taken a lot of our information and turned it around. I want to make sure you guys were aware of this as well. We have something called the Quality, Certification, and Oversight Reports. We used to have something called PDQ, providing data quickly. It's also a chicken tender chain if you're from certain states. So we had to change the name. It's a good chicken tender chain, so we're not trying to dissociate from it, but PDQ provides national data that you can break down to state and even regions within states of our certification and enforcement activities. And you can trend it going back 10 years. And it's a great resource. Up until a year and a half ago, it was secret. We hid it. And we hid it, it was before I was there, we hid it because my understanding was, folks said, well, if we turn this around and let everybody see it, we're going to have questions. And my response was, well, if there's questions we can't answer, then maybe we shouldn't be doing something. So we need to, if we're asking providers to be transparent, if we're asking them to look internally and improve their processes, we have to do the same. So when you go to the Quality Certification Oversight Report, you're going to see we have a lot of inconsistency across states and regions. You're going to see that there's a lot of things where we have outliers that we need to address. The fact that it was hidden doesn't mean that those things aren't happening. It's a great resource for you. It's a great resource for providers to look at what we're looking at with regard to their compliance activity. The Integrated Surveyor Training website, we used to have 3 platforms that we offered surveyor training on. And we also had surveyor training, guess what? Closed to the public. Part of that was because we had face-to-face trainings. And with face-to-face trainings, we had limited space. So we've now moved all of that into one platform, and we've moved it online. It's accessible to the public 24/7. Now we're going to change the name because once you integrate something, you don't need to keep reminding people that it used to be separate. It's no longer just a surveyor training website, and it's also not just about training, it's about quality improvement. So when you go there, what you're going to find is 95% of our surveyor training is now online. The information that we give to surveyors to go into facilities to evaluate quality assurance is now available to everyone anytime they want to go and check. There's no secrets with our program. The only secret we have in our survey and certification oversight work is when we're going to do a survey. Other than that, everything can and should be out to the public because it's a way for the public to know what we're looking for. When they're in compliance, we're all better. However they get in compliance is a benefit to us. If they do it by going on this website and doing things they need to do, that's great. So I encourage you to check out our Integrated Surveyor Training website. And then we have Nursing Home Compare, which we're really proud of and continuing to use, again, not just as a reflector, but as a driver of quality and doing other indicators on our star rankings and other things to help drive facilities to where we want them to be. Kate talked about the patients over paperwork and talked about how we need to seek, listen, and make changes that matter. And again, some of what I just discussed describes that. I will tell you that singularly, Kate has been living this. She's traveled more than I think any center director that we've had, out to rural facilities, out to Indian reservations, out to urban facilities, all different provider types, and just sits and listens. And I'll tell you something Kate does really well that I'm horrible at, and that's if we're in a meeting and there's an acronym thrown out or there's something thrown out that she doesn't understand, she'll say, wait, what does that mean? Now, when I'm in a meeting and I hear that, I just let it go because I figure I'll find out later, right? But that's no good. And what she's doing is saying, I'm actually listening. I really want to understand what's being said right now, and I want to hear it. And it's reflective in all of her actions and, frankly, the drive and the priority of our center. So it's something that definitely we need to continue to engage in and continue to do to get to our goal of improving health and safety and quality for everyone. We had powerful stories from the patients yesterday, and Jean introduced the panel that had the patient advocates. And I think one thing that we need to always remind ourselves is that patients and their advocates, their voices aren't unheard because they're not being offered. They're unheard because we don't take the opportunity to listen. And we need to continue to strive to make sure that we are hearing directly from the people that we're advocating and impacting their lives. And if we're not doing that, we're missing so much of the work we're trying to accomplish. And we're missing the opportunity to actually positively impact what we're trying to do. So we need to continue to seek out opportunities to engage and hear from folks. Every time we're in a meeting, you'll hear people say, well, this is going to be the best interest of the patients. This is the best interest of the residents. Well, you need to make sure you have the credibility to make that statement. And we need to continue to strive to ensure that those voices are heard and reflected in our policies. Yay! Hashtag cowbell. All right. We heard from Deidre Griffin about Medicaid, and it was interesting when she said, how many of you are engaged in Medicaid quality improvement? I know Jean had the follow-up of, we all touch a lot of everything, but we need to recognize what an important driver Medicaid is in healthcare and in healthcare quality. So 49% of the country gets their healthcare through employer-based insurance. Another 14% gets it through Medicare. 19% gets their healthcare through Medicaid. So if you're not thinking about how to engage Medicaid Medicaid providers and how to engage and incorporate your processes into those that impact Medicaid, you're missing out on a fifth of the population of this country. So it's important presentation, it's important information to know that we need to not be in a silo, that the things that work in Medicare aren't going to work in Medicaid. In fact, they're very complementary, and we should continue to always look for ways to synergize and align our programs together to make sure that we're driving for quality. We're not driving for Medicare quality. We're not driving for Medicaid quality. We're driving for quality. And we need to use all the levers and collaborations we have to be able to achieve that. Then we heard words of encouragement from Gene, and I think the thing that was most impressive for me was how many of you can have a quote from 20 years ago still be relevant to your work today? That's amazing. How many of you looked that good 20 years ago and would want to share it? That's equally amazing. But don't get discouraged. Don't get frustrated by the process. Don't think that things are always going to be the same and never going to change. And what you need to have is a resolute drive and passion to guide you to this work. What we do is not easy. It's not fun. It's many times not happy, right? But it's important, and it's vitally important. And the reason that you have to have that drive and energy is because of the positive impact that you can have on the lives of every single person you touch, and then people that you will never touch, and generations of people that you'll never touch. But you have the ability to impact their lives, and think about what an awesome, awesome job that is. So keep that passion, keep it burning, and keep moving forward, and don't be dissuaded or discouraged by anything that comes your way. I'm really excited to have Terry Lutz come up after I speak. A couple of things about Terry that I want you to know. He's fascinating. We were visiting before this. He's worked in the IRS, and he's a recipient of the Service to America Medal. Now, the Service to America Medal is the Samuel Heyman Award, and it's given with regard to excellence in public service. It's been around since 2002. There have been about 120 award recipients since then, so it's a very distinguished and honored award. They call them the Sammys, and they equate them to the Oscars without the movie stars and all the stuff the movie stars bring. But they're an impressive accomplishment to achieve. Dennis and Paul McGann and Jean Marie Williams got it in 2016 for their work reducing patient harm and readmissions. So we're in good company here to have two active Sammy Award winners here. It's like, a gathering of Nobel Prize laureates. The other thing that Terry did is he helped us to be able to e-file taxes. How awesome is that? Yeah. Now stop and think for a second. You just clapped for the IRS. You clapped for the IRS and talking about taxes. All right, but that's what Terry did, and that's why he's amazing, and that's how he's transforming and helped to transform the process by which we all go through and make it something that we can all do much easier. All right, so I think he's a great addition to the conference today, and I think that you're really going to enjoy hearing his message of again, how you can be transformative and positively impact the people you serve by taking processes that have been around and making them something that's going to be more effective, more efficient, and more welcome by the people who are impacted by them. So with that, I want to thank you all very much. Hashtag I care because I'm here on Valentine's Day, and I hope you all have a wonderful day and safe travels home. Thank you.
Please welcome Terrence Lutz, owner of Terrence Lutz LLC, former CIO of Information Technology Services at the Internal Revenue Service.
Good morning. I'm glad to be here with you. I think I was insulted. The comment about the Oscars, I'm not as good looking as George Clooney? Yes? Okay, I'm very glad to be here with you. When I was first called about this assignment, I kept saying, why? I don't know anything about Medicare and Medicaid, thankfully. But then I realized I'm 69 years old. I actually ought to be doing anything I can to help you all because sooner or later I'm going to need you. So I'm very glad to be here. I'm going to use some notes. I'm from a family of Southern storytellers. I use notes not to remind me of what to say. I have to look at them periodically to remind me what I'm saying now is not on the notes and I'm not supposed to be saying it. So I have a time limit here to stay with. But one of the things that I want to first show you is share with you a portion of a poem that I first saw, and I've never forgotten this, when I was in university. I don't know if I remember anything else from university, but I do remember this. But it's a section of Once by the Pacific by Robert Frost, which really talks about that instinct in each of us that wants to create, wants to do something, wants to be extraordinary, wants to be different. And it's that thing that often, for some reason or other, the education system and many times the workplace tend to kill on us and tend to take away. And I think anything I've accomplished in my career has been a combination of two things. One is an approach to work, and the second is the opportunity. If I'd never had been given the e-file job, you know how I got it? They had an opening, and I was the executive that didn't have an assignment at the time. Luck. But again, sometimes it's a combination of approach to work and being in that right place and opportunity to do the things that folks note with you. All of us are government workers, or we work with government agencies or around government agencies in some way, or we may be patients of government services. But the key is that all of us have heard about the lazy government worker or the vendor that's trying to rip off the government, and we've all known those kind of people. But we look around us and we know that's not the vast majority of the people that we know and deal with. And I firmly believe that each person, when they come into life, when they come into work, they came with an attitude, they wanted to have an impact, they wanted to accomplish something. And I think each one of us, no matter what our job, we each have a chance to do it. We have that process that's inefficient. Now, anybody want to tell me they don't have any inefficient processes in their office? A process that's inefficient, the problem that can't be solved, the things that take the fun out of work is a very important, I think, part of that. We've all had that moment that we want to quit, that we want to, as we say, throttle someone. Or we're the person who goes home and the kids are whispering in the corner saying, remember when she used to be fun? Because it carries over into our life. And I don't think anybody ever set out in life to really get to that point. So how do we break out of that mold or out of that situation? How do we become creative? And I think the answer to that is do what the kids would do, rebel. And I love this saying, creativity is the greatest rebellion in existence. Because what is rebellion? Rebellion's really about breaking out of what is uncomfortable, what we don't like, what we don't want to do. It's finding ways to get around that. Now, sometimes we can say the kids don't always do it in the most constructive way. Of course, we're going to be constructive about what we do. But the point is still that attitude that there is a way of doing it and that doing it is my way of rebelling. So how do we do that? So what I want to do is I want to give you some examples from some keys that I think in terms of how to approach work and how to accomplish things. First is to shoot high. Now, you can't accomplish something without first imagining it. People say, well, the apple fell on Newton's head and he discovered gravity. Baloney. He was already thinking about the problem. He was already trying to figure it out. That's why the apple resonated when it hit his head. If he hadn't been thinking about the problem, he would have never made the connection. I don't know if you've heard the story about Einstein, when the theory of relativity, the key dawned on him. He was walking home and he saw a clock church tower, and he noticed as he walked, the shadow on the hand moved. It was relative to position on the clock. It wasn't by accident. They were thinking about the problem. So if you can't sort of imagine a solution to the problem, there's not a problem. I want to give you a couple of examples of that from my IRS days. Back in the 1970s and early 80s, we had as many as 30,000 telephone assisters answering taxpayer questions during the filing season. And GAO had a way of measuring accuracy, and the standard was we were supposed to make 85% accuracy. I think our highest had been 67%. And what we did year after year, GAO would say they don't accomplish the goal. We would write a report saying it's impossible, they don't measure properly, you got this problem, we have to hire all these seasonal people, they only work with us a few months, we don't have enough money for training. And then we had a commissioner come in, a gentleman named Roscoe Egger, who said, I'm not going to have this conversation. So the only conversation I'm going to have is how we're going to get there. And there was money, and he essentially said, if you can't have that conversation with me, I will find somebody who will. Within 3 years, we made 85%, because somebody could imagine getting there. When I first moved into electronic filing, and let me say electronic filing at IRS started in 1985. Old hard wires between H&R Block offices and IRS. But as we moved towards the internet age, somebody in IRS had written in the mid-'80s, had written a report that said if IRS could get 80% electronic filing, we could close 8 of the 10 filing centers. And it was just a speculative report. Well, that got picked up and broadcast, and all of a sudden, IRS has a goal of 80%, and it isn't even close. I think when I took over the program, we were at about 14% at that point in time. And everything that we did was about arguing why we couldn't make the 80%, rather than talking about how we would get to the 80% goal. And ultimately, we were able to do that. I'll talk more about that. But the point is, you have to be able to imagine accomplishing it and stop making excuses about why you can't make it. There's an interesting story. George Dancing, a mathematician and scientist, in 1939, he had a class in statistics, and what the professor had done, had put up on the board examples of statistical problems that had no solution. And one of these was on the board, and on the other side of the board, he wrote up the 2 homework assignment problems that they were to solve by the next class. Well, George was late. So George came into class after it was over, saw these problems on the board, and wrote all 3 problems down as the homework. Went home over the weekend, came back, turned the paper in. A week later, his professor called him up and said, I've written a paper based upon your solution, and I'm going to make you the co-author of it. He'd solved the unsolvable problem, because nobody told him it wasn't solvable. So he solved it. And that was his start on his way to fame. So shoot high. Second, get out of the box. Now, how many times have people said this to you, get out of the box? Well, okay, and I love brainstorming, right? I'm the type guy, you do the brainstorming. We're going to go around the room and we're going to make this list of things. They go around the room. The second time I've struggled, I got the second one up there, and I'm like, please, please, please don't come around again, right? Well, see this guy in the picture on the slide? That's the guy who's in your office, who the 20th time around is still adding things onto the wall. Now, you'll say 75% of that stuff is irrelevant, what a waste of time. Wait, 75% is irrelevant means he came up with 5 good ones and you only came up with 2. So get out of the box. There are those out-of-the-box folks around everywhere. Another example of getting out of the box, and a lot of this comes from my career. I worked at IRS. You know what I studied in college? History. And then I got drafted. Draft number came out that took the military aptitude test. He said I'd make a great electrician. And then I ended up working for IRS. The long story there, IRS for all those years. But I think the advantage is I didn't have any traditional view of how things should be done. And it was, I didn't think of it at the time, but it was sort of an advantage. So when I first took my first job, one of the problems we were trying to solve was the problem of, you have tax auditors who have 6 hours of accounting, is all they're required. They audit you and me. And then you have revenue agents that are required to have 24 hours of accounting, and they audit the big complicated returns. They get paid more money. And the time I joined IRS, job market was tight. We couldn't find enough people. And everybody had been doing studies around why don't more tax auditors become revenue agents? Well, I just simply ask a different question. What are we doing to help tax auditors become revenue agents? And by changing the question, changing the perspective, getting out of the box, looking at the problem from a different angle, we came up with a solution to help pay for the classes so the tax auditors could actually afford to go to college. And so we did that in a little local office in Kansas. It got rewritten into national regulation and was implemented nationwide simply by looking at the problem from a different angle. Find the disruptive thinkers. And again, back to the guy, I love this because I don't know, is his head in the clouds? Or is his face underwater? What is he doing? But it really doesn't matter. He's looking at the world differently than most of us would look at it. So find the disruptive thinkers. One of the best examples in my career was in the 1990s, IRS was getting beaten badly, and we had all kinds of complaints about it. The Republicans had gone out and solicited comments from the public about mistreatment by IRS. And one of the things that you need to understand, you can say anything you want about IRS, and IRS cannot defend themselves unless you give them permission because of privacy. And they got all these complaints and didn't ask the taxpayer to get the authorization so IRS could tell their side of the story. Bad. But look, you get defensive, it doesn't accomplish anything. And part of the problem was that we were bouncing people all over the place. You had a collection division, a processing division, an audit division, a criminal investigation division, and you couldn't even find the taxpayer's case. So we hired for the first time, the Congress appointed a IRS commissioner that was neither a tax accountant nor a tax attorney. First time in history. He actually had been a McNamara whiz kid, and the Defense Department went on to form American Management Systems, sold the company, and was floating around. It came in with a management perspective, and he said, well, we need to change how we operate. Why don't we just put all the responsibility for a taxpayer from cradle to grave into a single unit and have that one unit handle everything? Can't do that. The world's going to fall apart. And it took about 5 years to do it. But we did it with everybody till this minute saying it wouldn't work. But again, that fresh look at the problem, because literally it took 115,000 people, threw them up in the air, and almost nobody landed with the same job they had before. Try that for change sometime. But again, looking at the problem from a different angle, the disruptive thinker. Find your allies. And this is interesting. Hopefully one of your allies is your boss. Now that's not always the case. But hopefully one of your allies, or you can find them peers or you have support. But the one example that was particularly relevant to the growth of electronic filing at IRS was finding allies in unlikely places. Congress had picked up this 80% goal thing and kept saying, why are you going to do it? And in the 1998 Internal Revenue Service Reform Act, they were actually going to write the 80% number in legislation. And we were saying, don't do that, we can't make it, we're only at 15%. How are we going to get there? And Senator Kerry, Rob Portman and John Kerry chaired this commission that resulted in this legislation, said, well, we understand it's tough, but we just want to keep the target. I said, yeah, but tell all the other 534 members that it's just a target. But then he said nothing, but he says, look, I haven't finished the legislation. Tell me what you want. What do you want in the legislation? And the one thing that we desperately wanted was the ability to advertise, because government agencies can't advertise. You can educate. Most of it's education. DOD has an exception for recruitment, but we asked for the ability to do straight Madison Avenue marketing, and they gave us that authority and a $20 million a year budget to go with it. And we produced television commercials that won awards against Coke and Pepsi and all the other players out there. And you saw these on the side of buses, on billboards. When you went to McDonald's, the paper liner on your tray was e-filing messages targeted at the young kids that work and eat at McDonald's. And one of the keys, without that ally, we would have ultimately made 80%, but not nearly as fast as we did, because we found the right ally that got the change that we needed to make it happen. The other is if it's the right thing to do, everybody has different opinions. But if it's really the right thing to do, there is a way to do it. Don't tell me there isn't. There's a way to do it if it is the right thing to do. One of the problems that we faced, and one of the things that led to the SAMI for myself, was this thing called free file. Most of the states and most other countries that had done electronic filing by this point in time in the early 2000s, everybody was doing it, you could go to their website, fill out your tax return right there on the website. But IRS, you couldn't do that. And the reason is this thing called A76. It goes back to the Nixon administration, which says where the private sector has staked out the ground and has developed commercial products, the government shall not compete with them. So because there was TurboTax and Tax Cut and about 20 other products out there, anytime there was discussion of IRS building its own website, these companies would go to Congress and say A76, competition with the private sector, and kill us. But apparently George W. Bush, when elected president, and his staff didn't know about this. And so in their first budget proposal to Congress, they put in language without talking to IRS. We knew nothing about it. Language that said IRS is going to develop an internet application so everybody in America can file for free. Political hell broke out because lots of people making money off of this. And so what but they didn't kill it. So what we asked for is, I said, look, let's not back off of it right now. Let's use this as leverage on the industry. And I spent 6 months of my life, the most intense 6 months of my life, negotiating with the tax software industry over how we were going to provide free electronic filing for the lowest income 50% of the American public. And there's a long story there about having that pressure. But at the end of the day, they started out wanting 30%. We insisted on 50%, or the president's going to do this thing here. At the end of the day, because of competition in the industry, 70% of the population was eligible to use it for free. Still is today. Now, this is the online stuff. Many people want to do it on their computer and have the copy of the return, not have it in the cloud. But 70% of Americans today can electronically file for free. That was a major, major booster to the change. But again, it occurred because if it's the right thing to do, there's a way to figure out how to do it. The only thing the industry got was a promise from IRS that we weren't going to build our own and compete with them. And in return for that, they give it to 70% free. The final point that I want to make about this, and before I close up here, is today, even with electronic filing, with everything, the first answer, got a problem, computers will solve it. Technology is going to solve it. That really wasn't the key. Now, the computers were necessary, but the key is not just the computers. In this particular case, what you have to do is you have to get the design right. And you've seen good applications and you've seen bad applications, but you have to get the design right. And that's really by designing it around not the way we in government operate, but the way the citizen works. Now, that's pretty standard stuff nowadays, but I think even in today's problems, it really comes back to it's as much about the design as it is about anything else. The other piece of that design feature is remembering how people work in their lives. For example, it's not just about the design, but for example, we worked with tax cut people, and we actually went into people's homes. We asked them to let us watch you as you're doing your tax returns so we could watch their workflow and how they work with the paper and so forth, and built those design principles in. So the point is, it wasn't just about the technology. It was that also, when we started to move this to corporate tax returns, the corporate tax return in the U.S., in paper filing environment, there were a dozen corporations. A single return, one return, was over 50,000 pages. The biggest one was 69,000 pages. How do you make that electronic? The main thing that we did was we scrubbed all the rules, regulations, and laws, and we made 1,800 changes to make the process simpler, more straightforward, including about 30 legislative changes that Congress passed. It's not just about the technology. Now, I will say there's lots of great technology out there for the kinds of problems you're dealing with. Blockchain has lots of potential, I think, in the healthcare arena, particularly around the records. Artificial intelligence, cloud computing. I was mentioning this morning, look at the ping-on Good doctor application that's used in China, teledoc and similar applications here in the US. So technology is part of it, but it's not the only thing. Design as if it matters, to wrap up on the design point. This is, I got this from the Cato Institute. This is the healthcare system in the US. Now, I know the healthcare system's bigger than you. They did this to illustrate the impact of Obamacare. Now, let's not get into politics here. The good thing about politics is it provides jobs for politicians. But again, so we can't deal with that. But the point I really want to make is design doesn't happen by accident. And it doesn't happen because anybody sat down and said, let's design this system. It happens by the day-to-day decisions that you make. The day-to-day decisions around the process, that rule that is necessary. Design tends to accumulate instead of happening by design. And I think that's one of the keys, particularly in government, is to how do you rethink that? And part of it is getting that outside view, as I mentioned before. Having the people who are in the healthcare field, both private sector, public sector, having patients engaged. We had lots of taxpayers engaged. But even taxpayers, even patients come in with their mindset. Sometimes it's getting the wild goose, the outside who has no stake in the game that can take that different perspective and look at how that design works. But the point is, change does happen. We did accomplish the goals that we had established at IRS around the 80%, around the free filing, and now over 90% of all taxpayers, that's almost 120 million people last year, are using the system. But I think part of this is, the key to this though, is don't forget this particular aspect of it. Creativity is intelligence having fun. We have the intelligence in the room. Now the challenge is to go have the fun. Thank you very much.
Please welcome Dr. Kara James, Director of Office of Minority Health at CMS.
Good morning. It is a pleasure to be here on today of all days, on this last day of the Health Quality Conference that we're having here at CMS. But we're particularly excited to be here because we're presenting, it's a new day, our CMS Health Equity Award. And it's exciting because when we think about where we've come, this is the CMS Office of Minority Health is a relatively new office in the government. We've only been here for about 6 years. And our first experience at the CMS Quality Conference, we had one session. And this year we had in our office hosting over 10 sessions that we had where we really have infused a focus on health equity throughout the conference, because you cannot achieve quality in healthcare if you don't have health equity. Thank you. So what is health equity? Healthy People 2020 defines this as the attainment of the highest level of health for all people. And when we think about what that means practically, it's really that reduction in health disparities and ultimately eliminating disparities in health and its determinants that adversely affect excluded or marginalized groups. So we've had lots of conversation about social risk. Where you live matters. Socioeconomic status, education, health literacy, language access, and performance there. All of these things impact our health outcomes, and really, unfortunately, they shouldn't. It shouldn't matter if you have a disability. It shouldn't matter if you live in a low-income neighborhood. It shouldn't matter if you have a high school education. You should still be able to attain your highest level of health. And the healthcare quality that you should receive should be just as high as that individual who may be a billionaire or who lives in the richest neighborhood in this community. And there's a difference between health equity and healthcare equality. Health equality, as you can see, is giving everybody the same thing, but it means that we have people still at different levels. Health equity is giving people what they need to achieve that goal and reducing those disparities. And so it means that we have to be intentional, and as they say in the UK, mind the gap. You need to focus on not just raising quality for everyone, because it can mean, as we consistently have seen, that as quality improves, and this comes from the National Healthcare Quality and Disparities Report, we've had over a decade of quality improvements across the board in all of our measures of healthcare quality. Unfortunately, we haven't seen the same reductions in disparities. So a rising tide does lift all boats, but you still, without minding that gap, can have health inequities. And so we really do need to focus on that gap and what we can do to reduce the gap. And so as we think about it, our path here at CMS, our path to equity, and you can, since we're in tweeting and everything, hashtag path to equity, is three-pronged. We want to focus on increasing our understanding and awareness of disparities, developing and disseminating solutions, and then through ourselves and you, implementing sustainable actions. This isn't easy work. If it were, we would have solved these disparities centuries ago. It's hard work, but it can be done. And it's one of the reasons that we're here today is to celebrate some of those individuals and organizations who have made progress. And it's also one of the things when we think about it's hard work, it's also, and I might be sadistic, it's fun. It's challenging, to take on these really meaty problems. And the reason it's fun is because when you make those steps, those incremental steps, that progress and those rewards are so much sweeter. And one of the other things that it's fun is because I have an amazing team that I work with. And some of them are here in the room, and you've seen them throughout the conference, and I'm not going to make them stand up because they don't like when I embarrass them like that. But they're a great team, and they take on all of these challenges. Sessions like we had yesterday where we talk about building a business case for healthcare, for organizational response, and building a business case for health equity. How do we make that case so that our teams get stronger and bigger, and we have more resources to focus on health equity? So we are a small and mighty team, but just to highlight a couple of things that we are doing within our path to equity, we have our building an organizational response to healthcare disparities. These are resources and tools that we've developed, such as our readmissions guide for reducing disparities, focusing on data collection so we can improve our understanding of disparities, as well as our ability to monitor progress. We have our action statement with our disparities action statement, and we have technical assistance that we offer for organizations. Some of you, I think, visited our health equity technical assistance room, and we know we had a good brisk business there, but we encourage all of you to reach out if you have questions. We're here to help. It's simply resources. If you want us to look at strategic plans that you're trying to put together, we're here to help you because it takes all of us to get to health equity. So with our CMS Health Equity Award, one of the big things that we wanted to do is to reward and support better outcomes for beneficiaries with social risk. For those of you who've read the ASPE report to Congress on social risk factors, this is one of the goals in which they recommended that we do. So celebrating the work that we are seeing across organizations in this space is something we wanted to take a moment to do. We also want to encourage those of you who may not have submitted for this year to engage in this space, to help understand the disparities that you have within your organizations and to address those, and to take an opportunity to disseminate some of those best practices and to show that at the end of the day, progress is possible and we have a results-oriented focus. We can get there. It'll take a little bit of time. So we were so excited. We put out a call for nominations and we received quite a number of nominations. And these are some of the organizations that we had submissions from. And then we had a wonderful team that came together from across the organization and the agency to review the applications and to look at sort of scoring. At the end, we weren't focused, as we said, on just the improvement, but really on those organizations who were minding the gap and showing reductions in that gap between our populations of focus. So our winner that we have is actually two. Sorry, that was, I previewed? Oh, good. I was looking at the slides. I was like, wait, I didn't give my chance here. We ended up having two awardees. One for an organization who did what we would like to call a sprint, who started last year with an intentional focus in reducing disparities, starting from the organization, having across their leadership, pulling together a leadership team that was challenged to address this, infusing this across the work of their organization, and delivering those results. And so our first Health Equity Award here at CMS goes to Navant Health. Thank you so much. Very excited. I'm going to have you guys come over here so we can get a picture. Thank you. And you can have a seat here. So, thank you so much. Thank you. So as you can see, Navant focused on readmissions rates for African Americans and discharge with pneumonia, and they showed a decrease of from 4% to 2% in the 9 months of their focused work, but also showed a 50% reduction in the disparity between African American patients and other patient population groups. So that's huge. And our second awardee is one who's had a long-term, sustained effort in reducing disparities and focusing on health equity. They serve an extremely diverse population across the country and have, over the course of about 9 years now, they've been focused on reducing disparities in hypertension. And so our second award for the CMS Health Equity Award goes to Kaiser Permanente for their efforts to reduce disparities in hypertension. I'm going to have you come over here a little bit. Take a seat there. Okay. So, get the let's move going. So we wanted to take a few minutes to speak to each of our awardees because this is learning in action. And so to hear from you guys about what specifically your efforts were and what lessons you might have to share with the audience today. So I'm going to start with Bernie, if you want to give us a few minutes of what you've done.
Sure. We started our journey a long time ago, and I think that equity work is probably some of the hardest work that we have to do in healthcare. We know how to do things, we know how to research, we know how to develop clinical practice guidelines, but then how do we implement them for such a diverse population? So the initial national data came out showing that there were hypertension gaps between whites and African Americans. And because of our structure being an integrated health system, we thought we did not have that same gap. So someone said, oh, we probably should run the data just to be sure, and lo and behold, we did. So while our gaps were the same across the nation, we actually were performing higher, so we were above the HEDIS national 90th percentile. And there was discussion of, do we put our resources there? Or do we continue to do what we're doing, which is try to give everybody the best that we can? And so we delved into that a little bit and really came up with a number of issues that we weren't expecting, like access, co-pays, all of the things that everyone is dealing with. And so then how do we as an organization start to address that? We developed several tools for our clinicians and the whole healthcare team. We started to move from care management to population management and really look at the clinical practice guideline for hypertension that existed for a long time and how was it being utilized across the organization. Were there ways that we could be addressing this differently? And then with that, we looked at cultural competence, cultural education, cultural responsive approach to how we address different populations. We had different pods, pilots, work groups where if you had a Spanish-speaking population, we'd have Spanish-speaking staff, and we'd try to get all of the Spanish-speaking patients to go there, and many of them did not like that because they thought they were getting a lesser level of care. So it was really kind of interesting with that. So we created tools for our physicians that were culturally responsive communication tools with the actual conversation. Here's how you should talk about each of these steps that are important, like introducing yourself, talking about the care that you're getting, the follow-up that you need, and then why it's important to this particular culture. So we did that for African Americans in this hypertension work, and we had a lot of resistance. It was really interesting, the amount of resistance, because we have a lot of good docs, just like everybody else does, and they felt like they were giving the best that they could to everybody. And so we started to talk about how things needed to be different for different folks, and it was really a big challenge. So if you think about hypertension and the research that's out there, it's been out for decades. We know how to treat hypertension, so why did we have the gap? And so we started some collaborative phone calls, and we invited everybody and anybody. So our distribution list was 500, and we would typically have about 60 to 100 on the calls. It took us about a year for some of our docs to see that it was important for the physicians to do this as well. They were fully on board for the care managers and the population managers to learn communication skills, but didn't think that the doctors needed it. So about a year, about a year into the program, they really started to see that. We have a physician hypertension lead in each of our areas, and they were really seeing the difference. The good part is that they were on all of the calls. And now I'm a nurse, so I'm pretty sure they were on those calls to make sure that a nurse was not telling a doctor what to do. But in that, we had great collaboration and a lot of work and a lot of success for our patients. The other part is no one can do this alone. So this was a collaborative effort between our quality department, our operation folks, our community benefit folks, our diversity folks. Leaders actively engage this. We have always believed in diversity within our organization. We have a diverse population and a diverse workforce. And then over time, we developed to language concordance. So physicians that speak the same language as the patients. We are not as successful with cultural concordance everywhere. We have it in some places, but we're continuing to look at that. And then if you look at our data, you can see we've plateaued over the last couple of years. So now our conversations are moving towards what do we do next? Have we maximized these benefits, or do we have new people coming in where we need to do more training? So it is an ongoing journey that I think we're still at the beginning of it, even though it's been a number of years.
Thank you. So, Tanya, tell us about your journey and how you guys, particularly what led you to start this.
Yeah, thank you for asking. For us, it really started with our mission, and our mission is to improve the health of communities one person at a time. And what that means to us is that we want to provide remarkable care, individualized care for patients in the right place and at the right time. And so we knew we had that as our mission. We have a core value of diversity and inclusion. We've had that since our inception. But 2 years ago, we made an intentional focus to say, what does that really mean? What does diversity and inclusion really mean for our system? Very fortunate to have our president and CEO, Carl Armato, who said, that means we're embedding diversity and inclusion in every single thing we do, which included health equity. And so from that, we started thinking about what does that really mean, health equity, and how do we make sure we're doing what we're supposed to be doing? And of course, we thought we would not be giving different care to anyone. We all think that because that's never our intention. Well, then we looked at our data. And the data initially said to us, you all are great. There are no disparities. We only looked at 1 year's worth. There are no disparities. And our team, and you saw our team a few minutes ago, Jeremy and Lakeisha and Gina and Wendy, we had a whole multidisciplinary team. The physician that was on our team is not able to be here today, Dr. Larry Weems. But so we said, okay, let's look at the data for this year. What we learned in the Disparities in Leadership program that we enrolled in is that if you don't find disparities, you haven't looked deep enough. Well, we looked deeper. And what do you think we found? Disparities. We found that the African American population readmitted at a higher rate than our Caucasian population. And our organization had been doing a lot of work on pneumonia. We have a readmissions committee system-wide, and there's been a lot of work being done. What was different about this work is exactly what you said, Kara. We started minding the gap, that there was a gap between African Americans and Caucasian patients, and we needed to understand why. There was a 4% gap. So we put this team together, we looked at the data, and then we actually did chart reviews or electronic records, and we called our patients personally. So we called every patient that had a diagnosis of pneumonia and talked to them. We had like 28 factors that we looked at. We wanted to make sure about their medication. We looked at if they were getting case management before they were discharged. We looked at if they had supports at home. We wanted to know if patients followed up with their doctors like we had recommended prior to within 7 days. And we wanted to know if the case managers were following up with our patients in our population health department, similar to yours, after discharge. So we looked at a lot of things, and we found that there were gaps, that for the African American population, some of that was not happening. And so we put the case managers were on our team, and so we started looking at why. Why was this not happening? One of the things we found out and that we implemented was that our African American patients were not going to their follow-up appointments within 7 days. So we put a process in place in the hospital that we scheduled the appointment. We didn't allow people to just make their own appointments because people get busy with life and think they feel better and they don't do that. So we scheduled the appointments. We also we created a list for our case managers to know who the pneumonia patients were in the hospital so that they could make visits to them prior to discharge and assess their supports. We did a lot of education. You were talking about cultural awareness. We had to do a lot of education with our team on what were the needs of the pneumonia patients and what was happening to them. We employed or hired pulmonary navigators that actually helped the patients to navigate our healthcare system. We're working on a pilot to have community health workers that will go into the homes and do more work in the homes to assess their resources and their needs. So it really was a team effort to make sure that this process worked. Some of the challenges or lessons learned is that diversity and inclusion for us is not about a program. It really is about how we do our business. And Carl Armato, our president, has said that there's a business case for diversity and inclusion, and there's a mission case for diversity and inclusion, and we have to fulfill both. So for us, making sure it wasn't a program was really important. It's really, for us, a culture change. Yes, we care about all of our patients, but it really is a culture change strategy. And when we go out and do education, we had to first talk about what is diversity and inclusion and why is it important. A lot of people initially thought diversity was about black and white, it could be a riot, or gender, maybe gender. But when we really kind of expanded the knowledge base of people and what it was about and how we truly wanted to take care of all of our patients, it got a little easier. The team has gone out and they've done presentations with our clinical improvement groups. They've gone all across our organization. The other piece that was really important is our Board of Trustees. Our Board of Trustees totally is holding Novant Health accountable for embedding diversity and inclusion. And so we have metrics we're developing metrics. We have several that we have, and we're even developing more metrics for our health equity component. We've establishing a health equity council, and on that council, we're going to require each service line to tell us where their disparities are in their service line, how they're going to identify, address that, and then eventually eliminate the disparities and close the gap. So we're very excited about the work we're doing. We're not finished, and we will continue to do the work. It's exciting and challenging at the same time.
Thank you. So for both of you, you started with your data. And you looked at those disparities, and I guess to one question, for the audience out here is like, where do you start? And so it's we like to say it's not almost what to do, it's just where to start. So how did you sort of determine hypertension, pneumonia, readmissions? Like, what was the pressing sort of issue there?
When the national data came out, it was hypertension specific. So we looked at that, and then we went to the HEDIS core measures, and we stratified all of the HEDIS measures by race, ethnicity. And we have a national quality committee where our different region quality leaders come together. And there was discussion there as to where we should focus. And so hypertension was chosen as an outcome measure, even though cardiovascular disease really is the outcome, but for learning purposes. And then we also looked at colorectal cancer screening in Latinos as a process measure, and thought that we can take these two, put some concentrated effort there, and learn and spread. And there's a lot of collateral improvement that happens when you do this. So we saw all of our populations improve. So in the first year or two, the gap wasn't really closing because everybody was improving. And so then we had to look at, well, okay, what else do we need to do differently? But it is the data that makes a difference. The other thing that we did when we first started is we had an summer intern who did an internal white paper with our quality folks about this work, about disparities. And everyone said, oh, I'm sorry, you're talking to the wrong person. You should talk to our diversity leader. And so it was really quite interesting. That was across the board. So that was square one, right? If you look at quality improvement techniques, the first thing is to bring the problem to someone's attention in a way that they understand it. And so we were able to do that between the data and one of our senior leaders saying, this is a clinical outcome, you own this, you do the HEDIS measures. So it took a little bit of emphasis there. And our board of directors, just as yours, was 100% behind this as well. When we showed the slide to the board of the data, they just looked at it and said, okay, well, we know where to start, because there's all these lines of different color, different races, and then there's white space, and then there was the pink line, which for us, the pink line is African Americans. So it was very clear where to go once we had the data. And when you look at that, it's hard to say for us, program-wide for us, okay, where do we start, right? That's just directional. So from there, we broke it down by region, and you would think it was all different companies because it looked different everywhere. Some places, the end to goal was 25, and in others, it was 10,000. So while we had a common approach, it certainly was tweaked for local geographic areas.
And for us, we have a readmissions committee for our organization, and so we were looking at pneumonia, heart failure, all the CMS core measures. We decided on pneumonia, not knowing there would be a disparity, because our hospital list see 95% of our patients in the hospitals. And so we knew we had a captivated audience of hospitalists that we could really work with, and they were part of our team to look at our patients. And so we chose pneumonia for that reason. And we were really glad that we did. It wasn't so big that we couldn't get our arms around it, but it was big enough so that we really could make a difference. And so, as I mentioned, we looked at the data for 1 year. We didn't see any changes. We didn't see any disparities. When we went back 2 years, what we saw was that the African American readmission rate got worse each year. And so if we'd only looked at 1 year, we would have said, we're great. We just need to stop. We don't have any disparities, just like we said. But we found that. And what we also realized is that if we had not mined the gap and paid attention, the African American readmission rate would have continued to get worse. In this process, and when you were looking at a particular population and you're looking at care across the board, as you said, care improves. So what we found is that the readmission rate for our Caucasian patients also decreased, got better. They were readmitting at a lesser rate. So in working on the African American population, we actually improved care for everyone. But that is how we chose that.
So this isn't easy work, and you've talked a little bit about some of the challenges you had, and particularly, I'm sure we'd all love to hear about how you brought the physicians on board. But You know, if you were to take one challenge, like what did you do to overcome that to help drive towards the outcomes that you're seeing?
Well, I think it's diligence, persistence, and finding those who are passionate about it. So for me, I was learning this work as well. I started doing this disparity work because I had an opening in my workload. And so my boss said, could you start doing this? I'm like, sure, but I don't really know anything about it. So I was learning just as everyone else was. And I knew quality principles, quality improvement principles, so I thought, okay, well, we can make this work. And I was just persistent with our docs and talking about it. And I found physicians who were passionate about it, and I'd get them on calls together. We had one physician who thought, well, yes, this is important work, but we should put our resources elsewhere. So I would do a call with another physician that was passionate, and they'd say, well, you know, this really is important, and they'd convince them. But the other part was really being consistent and persistent on our collaborative calls. So we would do a 1-hour call, 20 minutes for someone to share something that was working well in their area, and all of the rest of the time for Q&A. And there were docs that joined the call, and our physician leads were all on the call, even though they didn't think the doctors needed it, but they always joined. And they heard other docs asking questions. And so this is a phone call, and I used to say, oh, I could see the light bulbs going on. Because a doc would ask a question about our clinical practice guideline, and then one of our physician leads would answer it, and we really identified that there was a greater need for education in that area. And I think overall we've identified in this space that we have a greater need for education, both clinically and culturally. And so that really has made a difference in how we got everybody to come on board and step past that challenge. And now as we move forward, we're looking at what are the things that we do differently. And we also are celebrating this more because we look at 3 years of data and we're saying, well, we're not really making a whole lot of progress. So then we went to what we call our long charts, and we showed from 2009 up to current date. And you can really see a big dip in cutting the gap in half. And in colorectal cancer screening, we cut that gap by 75%.
Before becoming the Chief Diversity and Inclusion Officer, I was actually the president of 2 of our hospitals. And so, and started my career as a social worker, so really understood patients and some of their needs. I think for us, and the biggest challenge to overcome was really understanding that diversity and inclusion and health equity was not a one-off, that it really was a part of our business strategy, it was a part of our mission. And I believe we've turned the corner with that, that we've been doing that. So people are now asking for a health equity analysis of their data. If they don't ask for it, our informatics team actually provides it. So I think that was the biggest challenge that we've had to overcome is for people to see it truly as a part of their work. And we can't become complacent, which is something that would keep me up at night, is complacency. We have to continuously tell the story and show how it integrates into every single thing we do. On the board, I'm now working with the governance and nominating committee of the board because the metrics and diversity inclusion kind of lives there for Novant Health, lives there in terms of holding us accountable as an organization. And so what they've said is that we also have a quality committee, and now that quality committee is also going to be responsible for looking at disparities and reporting those to this group so that we can report it every quarter to the board.
Great. Thank you. So in the last minute, we talked about putting patients first and having to, encouraging us to listen to the patients. So how have you guys maybe worked with the communities that you're trying to serve to reduce the disparities that you've seen?
Well, community engagement is critical. In several of our areas around the country, we work with barbershops to help them understand how to not only check blood pressures, but even blood glucose. So that's been huge. We're also partnering with the American Heart Association in the San Diego area on their work around faith-based leaders and having those folks really encourage their congregations to develop trust with healthcare and to also look at their lifestyle changes. So engaging in the community has really been significant. We do the community health needs assessment. So each area, because geography makes a difference, each area uses that to look at what their needs are and what they need to do. So we have quite a few different activities. We have community gardens, different things in different areas, help with walking paths. I think actually in the Baltimore area, we were engaged in that. So lots of different activities, and we're actually now using the Your Current Lifestyle survey to really see what patients' needs are and how we can connect them to resources individually within the community as well.
We also do a lot in community, and that's very important to us. We have actually a community wellness and education area that is led by a physician in our organization. So they do a lot of health screenings and wellness education in the community. We also have business resource groups that are configured by their own population. For example, we have a women's group, we have an Asian group, we have an African American business resource group, and those groups actually help us to see what the needs are in the community, in addition to the community needs assessments that we use, and who we should partner with in the community. So we have a lot of partnerships so that we are not reinventing the wheel, but we're actually working collaboratively across our markets.
Thank you. And please, again, join me in congratulating both Kaiser Permanente and Novant for their excellent work.
Thank you.
And we hope that even more of you will consider submitting and showing us how you are minding the gap in application for next year's CMS Health Equity Award. Thank you.
Thank you.
And now, please welcome Dennis Wagner, Director of Quality Improvement and Innovation Group at the Center for Clinical Standards and Quality.
All right. That was a fantastic program, Kara, and congratulations again to Kaiser and Avant for your work. It really is spectacular. So my job here in the next several minutes is to wind up, and that is the way we do it, right? We wind up, we don't wind down. And I'll just say, for one, I am pretty wound up as a result of these last 3 days. You all have made this an extraordinary event for all of us. I think we get an incredible boost of learning, of insight, of connection with each other, and energy by coming together. Now I'm going to just briefly, I want to start where we began, and we had a number of key purposes here when we came to Baltimore for the CMS 2018 Quality Conference. And I'm not going to reflect on all of them, but I want to call out a couple. One is to align with the priorities of the new administration. And you heard from Seema Verma directly, from Kim Brandt, from Kate Goodrich, from the senior leadership of the agency, what those priorities are. Burden reduction, opioids, moving away from fee-for-service, fewer, more meaningful measures, cost savings, addressing disparities. I think this is just crystal clear. I think we heard it, I think we understand it, and I think we're embracing this, and the results that we're already generating on these fronts are showing it. Now, we also asked people to come here not to just listen and learn and kind of enjoy the speakers, but to commit to actions. Dr. McGann challenged us all, like maybe 5, maybe even 10. Let me just check in. How many people here made a commitment during the course of this event? Like, is there anyone here who didn't make a commitment? And I think I see hands all throughout. How many people, I just want to check in on this. Anybody here feel like you made 10 commitments or more? Anybody here in that category? Yeah? I see a few. I know I'm well over 10 myself. Like, there are a lot of requests that come to CMS in an event like this, and our aim is to say yes when we get those requests. So a lot of commitment. We also took some time to celebrate results and have fun. I think the results that Kara James just celebrated with Novant and Kaiser are just spectacular. But I was in session after session where we acknowledged TCPI, high performers. I saw just a beautiful session yesterday on patient and family engagement. Not only that patient and family engagement is occurring, but the linkage of patient and family engagement systematically to results. I mean, it's just spectacular. Our clinician champions, patients and caregivers, a wonderful dinner a couple of nights ago with the ESRD. We had more than 25 ESRD patients here, together with a lot of other patients that participated in this event who were acknowledged for their work. The QIIG, Quality Improvement Innovation Group coins, a lot of those were given out. Had an opportunity yesterday to recognize some wonderful folks for results that they're doing throughout the nation. And a lot of my colleagues participated in giving out those Quality Improvement Innovation Group coins. And then one other key purpose that I just want to acknowledge was the systematic, deliberate, intentional inclusion of patients. Not just in this conference, but in our work throughout. We're seeing that over and over and over again, and it makes us all better. It makes us all better when we do this. We're not doing it to the extent we need to, and there's a lot of room for improvement, as there is on much of our work. But the systematic inclusion of patients in our work is something that's happened here, and it's something that's happening more and more and more throughout our quality improvement activities throughout the nation. And I'd just like you to join with me in recognizing, Libby Hoy, Natasha, David, Alan, Desiree, Jody, all the patients who have been such an important part of our work. Join me in thanking those folks. I also just want to say we got some great advice. Like I have to say this morning, listening to Terry Lutz, there were so many gems there, but like this idea that creativity is rebellion, like that's something I can latch onto and use. So Gene, I want you to know this is coming your way, all right? Creativity is rebellion, okay? That's like really something. And just the business of you got to imagine it first. I think that is absolutely true. And I think events like this really help us to imagine the way forward. The idea that design is a day-to-day thing, another just very powerful gem. I think just extraordinary. Now, as we wind up, it's really important to thank a number of key people in addition to the patients who have been such an important part of this. And I want you to join me in recognizing the folks here, our AV team, the Marriott Hotel, the Bazell Group, all the folks who are behind the scenes that make this thing run. Please join me in thanking those folks. Good job. I mean, this is a big event. 2,600 people, all these sessions, a lot of demands. And I heard yes, yes, yes all the time as we made requests of folks throughout it. Secondly, there is a quality conference work group that really organizes and designs this entire event. I think we might even have I thought we had a picture, but actually we got a list of the folks that are involved in this. So these are the people that organize the sessions, that align the sessions with the leadership agenda, that diplomatically limit attendance. We only have room for 2,600. We know that the demand for this event is more like 5,000. So figuring out how to manage that dynamic and doing it gracefully and creating some flexibility around that, these are the kinds of demands that are put on the Quality Conference Work Group. And I'd like you to join me again in thanking these folks for their contribution. Now, there's a very special member of the Quality Conference Work Group, and her name is Monique Endinacho. And I know many of you know her. I believe that about half of you have called her, and the other half has emailed her, right? So like this is a person who is at the center of the action making this happen. And she has kind of at the core of her being the word yes. Like you come to Monique and you make a request, and she just never hesitates. She just says yes. And it's not me. I mean, I am one of her bosses. It's everyone. I witness it, and it's central to her being. This is a person who is helpful, who is friendly, who is solution-centered, and most of all, she's calm. Now think about this. Like we got a 2,600 person meeting coming to Baltimore, we've been planning this thing for like 4 months, right? And we have a government shutdown looming at midnight Thursday, right? And she's just charging forward, like not a sign of hesitation or worry or fretting or anxiety or any of that, at least none that we can see. Sometimes people on the inside are different, but everything that I could see about Monique is this picture of calm. I mean, it's amazing. And a couple days before the looming potential shutdown, we asked her to develop an options paper for what are we going to do if there is a shutdown, right? And she cheerfully assembles, we can cancel it, we can postpone it, or we can run it anyway. We're like, run it anyway. Yeah. And she explains how we're going to run it anyway. And so we share this with our senior leadership, and of course it didn't happen. We didn't have a shutdown, right? But I am happy to say that our senior leadership were like, we're going to do this anyway. We're going to make it happen anyway. Now, it turns out we didn't have to pull that trigger because Congress got a budget together and we were able to charge forward. I'd like to call Monique Endinacho up here to the stage. And I want to present her a double. Wow, look at this.
Thank you.
All right, good job. So for the record, that was a double cowbell, double cowbell, and a Quality and Improvement and Innovation Group coin. The first coin, to my knowledge, that's been given to anyone in our group. So thank you, Monique, for just exceptional work. So I am a social marketer by background, and one of the central tenets of social marketing is repetition and reinforcement. So as we wind up, I want to say something here that I say a lot. And in fact, I think I said it last year at this time. But I think it's just so central to our work. I learned many years ago that you can't be a beacon if your light don't shine, right? So you can't be a beacon if your light don't shine. I think a lot of us know that. And that there's at least 2 ways to bring light into the world. You could be the candle that generates it, right? You can be the candle that generates it. And we have candles throughout this room that are generating results, that are moving forward on important priorities, that are serving patients, serving caregivers, serving providers. We have a room full of candles. Or you can be the mirror that reflects the light. And for many years, I saw my own role in the work that we do with quality improvement as the mirror, that's really reflecting back the light of these tens of thousands of candles, really millions of candles that we work with every single day to make healthcare better. But I think what I've learned over time is that we all of us, we have the choice to be either or both all the time. You can be the candle that's bringing light into the world, or the mirror that reflects it. So I just want to, as we wind up, thank you for being candles, thank you for being mirrors, and encourage you to keep charging forward in those 2 really important roles. Thank you for being here, putting patients over paperwork at the 2018 CMS Quality Conference. Good.